All right, welcome everybody to AADE 2019. And on behalf of Becton Dickinson Diabetes Care, I'd like to say thank you all for coming and spending your lunch with us today. We'll be reviewing a product theater around BD Nano's second generation pen needles designed with patients in mind. My name is Tom Filma and I work within clinical marketing at BD. And I'm very excited to announce two esteemed colleagues of mine who will be presenting today's product theater. First, we have Donna Jornze, who joins us from Mills Peninsula Medical Center, where she's the Diabetes Program Manager and Clinical Specialist in the San Francisco Bay Area. Second, we have Mo Shanahan, who is the Senior Medical Science Liaison for BD Diabetes Care in the US. And with that, I'll transfer over to you, Donna. Thank you.
Good afternoon, everyone. Can you guys hear me? Okay, great. We are going to take you through first the learning objectives and then some of the science behind the changes with the BD Nano second generation. So first we're going to review injection technique recommendations. These have been around for a while but have just recently been included in the ADA 2019 standards of care. We want to understand the current state of injection technique practices across the US. We want to discuss the critical role we as CDEs play in improving care for patients living with diabetes and also improving their techniques regarding injection therapy. We want to review some recent findings which highlight some of the challenges that are still present around proper injection technique. And then we're going to introduce this second generation nano pen needle as a solution to make injections easier for our patients. So injection technique recommendations have been around for 20 years, but it's really been only the last couple years where I feel like we've really focused on this more. And there were a number of conferences that were put on, first in Europe and then most recently the 2015 FITR conference, which was in Rome, Italy, and I was privileged to be a member of that, which represented professionals, hundreds of professionals from 423 different centers and 42 different countries. Those findings from that FITR conference were published in the Mayo Clinic proceedings in 2016. And if you haven't seen that document, I highly, highly recommend it because it gives us some very specific recommendations around teaching injection therapy to our patients. So recently, as I mentioned, the ADA included this in January in their standards of medical care, and they said that proper injection technique may lead to more effective use of insulin therapy and as such holds the potential for improved clinical outcomes. So what did the ADA emphasize in this new section in our standards of care? Well, key among the recommendations was that we want to be using shorter needles. Shorter needles are quite important in us reducing, not only are they better tolerated by patients and definitely eliminate a lot of the fear factor for our patients when they see those shorter needles, but it's also critical in decreasing the percentage of our patients that are actually getting insulin intramuscularly instead of subcutaneously, which is where it is intended to be injected. We also want to, those of us, let me say this in a politically correct way, those of us living with diabetes seem to regard that the next depression is right around the corner. So we think we have to reuse needles. And I've had type 1 diabetes for over 50 years at this point. And so I do remember those times where people were saying, oh, you can reuse needles, and I've had patients tell me they use 2 needles a month. What we do know is that needle reuse has some significant clinical implications, not just on decreasing comfort, but also increasing lipohypertrophy. And our injection technique rotation and how we can do that and teach that most effectively for our patients is important in avoiding lipohypertrophy as well. So we want to inject insulin into that subcutaneous tissue, or we're going to have very much less predictable insulin absorption if it's injected into muscle, and a potential increased risk for hypoglycemia. So I take allergy meds, which constantly dry me out, so water. So what does proper injection technique, how does that impact a patient's overall diabetes management, their glycemic control? So we've had a number of studies that show us that it does impact it. And in 2015, or no, it was 2014, the Grazi study showed us that doing structured injection technique teaching really, and that training could really have an impact on both changing the needle length that patients use away from longer needles to shorter needles, being more rigorous with their schedule of site rotation and how do they actually rotate those sites, the issue of needle reuse, and the resulting lipohypertrophy that comes from not doing those other things well. And what Grazi and colleagues were able to show was just about 6.6% reduction in A1C when patients received that structured training. And who better than us as CDEs to be delivering that structured training? The Mishnikov study, which was just published in 2017, I believe, also showed us that switching to those shorter needles had an impact that resulted in a 1% reduction. They did that study for 6 months. So at the end of 6 months, the reduction in A1C was 1%. These are important not only to improve and decrease our rate of complications that we see in people living with diabetes, but also to have insulin be more effectively absorbed and result in that reduction in A1C. So when we think about this and proper injection technique, how widely are these recommendations being adopted by not only our patients, but our providers? And what challenges still exist as we try to explore this topic? I've been out in the San Francisco Bay Area for the last 2.5 years. And before that, I was at Long Island Jewish on Long Island for a number of years. And we did a big transfer from the 12.8 millimeter needle. We had gotten away from insulin pen use in the hospital, and we went and we had a 12.8 insulin syringe, and we switched that to the 6 millimeter BD insulin syringe and reduced our inpatient hypoglycemia rate to half. Why? Because a lot of those injections that we were not perceiving were being delivered intramuscularly were in fact being delivered intramuscularly. So injection needle length in injection technique is very, very important. And we also know that many patients do not change from that initial needle length that they got, and they just keep refilling that prescription. So this is something we're going to talk about a little further. We're also going to talk about what new recommendations have come out from the FDA regarding removing the outer and inner cover of those needles. Clearly, somebody who's attempting to inject with a needle cover on is not going to get the benefit of the insulin. And then the third issue is injection force variability. So we're going to talk about all three of those factors. First, let's look at needle length over time. So the 4 mm needle came out in 2010. And if we look at 2009, you will see that there is no 4 mm, which is represented by the orange bar on that graph. So you see there is none. So by 2014, we had about 20% of our insulin using patients using the 4 mm. And that use has increased slowly to just a little above 40%. And you can see that the 5 mm needle use has been fairly consistent, as has the 6. 8 mm needle use has decreased, but the 12 has been fairly consistent as well. And that is the needle length that, at Long Island Jewish anyway, was giving us significantly higher rates of hypoglycemia in our inpatients who were getting injections by nurses using good technique, but a needle that was too long. So this is something we want to be making that recommendation to our patients, that the shorter needle is better. The 4 mm needle has been evaluated with people with a BMI up to 50 and is depositing insulin into the sub-Q space because most patients' skin thickness is not more than 2.8 millimeters, regardless of gender, regardless of race, regardless of obesity. What happened in 2018? In response to reports of hyperglycemia, DKA, and one patient death, in September of 2018, the FDA issued a safety communication that went out to all insulin manufacturers and also the manufacturers of insulin pen needles. And what this was about was previously the IFUs said remove the needle cover, remove the inner shield. They wanted that represented by two separate slides: remove the outer cover, remove the inner cover. And I personally had a patient in the last 2 years in California who had her insulin dose increased 4 separate times and thought that she was receiving insulin when she still had that tiny little pale green needle cover on and wasn't receiving any insulin at all. So this is an important thing that really we do need to educate patients about. Although to us it may be obvious, it obviously is not as obvious to many of our patients living with diabetes. So the warning that was issued was remove both the outer cover and the inner needle cover before an injection. If both the outer cover and the inner needle cover are not removed before use, the medication or dose may not be injected, which may result in serious injury or death. Now, the issue of injection force variability is probably the thing that we as diabetes educators have paid the least attention to and know the least about. And this has evolved in the last couple years. So we're going to show you what is the amount of pressure needed against the skin during an injection, and also what are the implications of using greater than that injection force. And it's going to cause potentially increased pain. It's going to cause potentially unpredictable insulin absorption, particularly if that injection becomes intramuscular. it could lead to an increased risk of hypoglycemia and poor glycemic control. So we want people injecting so that the needle is level with the layer of skin and not pushing, indenting that skin as they're doing the injection. So what has BD done in this arena to really look at what is the injection force people are using? They've been able to measure that injection force with a sensor that was connected to the CPU and allowed us to capture data. And any of you who are interested in seeing what your own ability is to demonstrate that without having, can do that at the BD booth, and they'll send you your own graph. I'm going to show you some graphs now. So this is injection into the thigh. And if you think about a patient sitting down, let me move this over here so you can all see me. If you think about a patient sitting down, the easiest spot would be to do that injection directly into a thigh, right? But that is also the spot that typically has the least amount of subcutaneous fat. So when we're doing that, if the injection force needed is only 1, how do we measure this? What is that, Tom? 1 pound per force? Pound force. Didn't know. Pound force, we only need 1 pound force, and we had people injecting up to 4.5 pound force. And this was done with not just patients, but with educators. And even us as educators were using a greater pound force than was needed. Now, with the injection, you can see that we did a good job at having people hold it for the whole 10 seconds. But many of the let's go forward. The pound force involved was in numerous occasions a lot more than what was needed, and could in a thin individual, particularly if they were using the thigh, result in an intramuscular injection. So injection force varies by user. It can also vary by the same user on different injections. So there are several factors that contribute to the injection force variability, including the injection site, as I mentioned. So we're probably better off recommending people consistently use the abdomen or getting away from the areas per individual that have the least amount of subcutaneous fat. The injection force can vary based on the volume of the injection. The perception of many patients is if I'm giving more units, I have to push this in harder. I need to have a greater injection force. And the device grip is really critical and something I'm not sure we have focused enough attention on as educators to have our patients be properly using the correct device grip. So here were some patient observations that actually measured their injection force. The top, this is the correct technique. One-handed with the thumb on the plunger, but injecting first before the thumb is added to the top of the plunger. So you're not letting insulin out before it's in the tissue. You can see here that we have somebody injecting at more of an angle instead of straight in. Here we have, they're using an injection pad to demonstrate the force, but they have a fingertip on the top. Is that the right amount of force? Maybe not. Here we have the right thumb on the top, but we're using a skin fold. Do we need a skin fold? We don't with the 4mm needle. We do not need it in a skin fold. And in the last picture, we have a major pinch up of skin in an abdomen that doesn't need a pinch up. Yeah, some of us have that problem, don't we? I don't need a pinch up. Based on the information that we obtained from these user studies as well as professional studies looking at device behavior, BD has redesigned that nano needle to help make it easier for our patients to adopt the correct injection technique. So the range of difficulties that people have using pens, they could experience difficulty removing that inner shield. And I'm sure all of you have had the same experience that I have, that the older the patient, the less manual dexterity they have, the more difficult that process has been. They may have difficulty actually attaching the pen needle, and the new design on this helps significantly with that. They may be using different amounts of applied force with different injections in different body sites with different doses of insulin. And the instability, and I'm sure you've also seen this, particularly if you have a patient who has any tremulousness, that needle is actually wobbling around in the skin. So the new design of the Nano 2 helps correct for that. So now, Mo, it's your show.
Thank you, Donna. You good? Can you guys hear me in the back? Yeah, okay. Thank you so much, Tom, for the introduction. Thank you, Donna, for setting the stage so nicely for all of the issues that our patients are facing right now. And thank you all for showing up and spending your lunchtime with us. Donna has nicely illustrated some of the issues that our patients are facing with insulin injection technique. I have been with BD as a medical science liaison for about 7 years, and one of the things that I have been always impressed about with our company is that we are definitely patient focused. We really want to do the best that we can to improve the patients' lives with diabetes, and certainly those on insulin therapy. So with that in mind, there are a couple of things that we do being a medical device company. One of the things we do is we try to make the best quality medical devices that we can, and I think we do obtain that. I think we do put out very good quality medical devices. But in conjunction with that, we also put an enormous amount of focus on education. We want to educate healthcare providers and we want to educate patients about how to optimally use these devices properly so they get the best bang for their buck. So Donna has illustrated some of the issues that have come to light over the last few years. And if you've been around, I've been working in the diabetes field for a very long time. I'm a hospital pharmacist by training, and I've been in the industry for a while. But I come from the beef and the pork days of insulin. I remember U40, U80, U100. We've seen lots of changes in the last 40 years, haven't we, with insulin therapy, devices, et cetera. And every time we have new innovations, it certainly does add to patients' positive experiences and things are better for them, but there are things that come about with these new devices and these new medications that sometimes cause a few little issues. For example, the new safety communication from the FDA about the inner shield. Back in the day before we had pens, we just used syringes. There was no inner shield, so there was no problem with removing the inner shield, right? So we got pens. Pens are a wonderful addition to the devices that we have. It makes it so much easier to give insulin with the pen than it is with a vial and a syringe. But with that comes this little issue with the not taking the little inner cap off. And so one of the things that what's incumbent upon us as a medical device company is when our knowledge advances and when we learn of issues and the science advances, we need to address that. And there are a couple of ways that we can address that. We can address it through education, so we educate you as healthcare providers, we educate patients on how to overcome some of these issues. But that puts kind of a burden on the healthcare providers, and it puts a burden on the patients. It's essential, but it also goes hand in hand with our developing medical devices that sort of take the worry out of remembering all of these things. So take, for example, the example of force variability. This is something, force application and force variability is a new concept that, as Donna mentioned, we haven't really thought so much about it. Now we know that this causes some issues. If patients, we call them gentle injectors or jammers. I'm sure you have seen all kinds of ways that people are injecting. If people are injecting gently, that's probably fine. The insulin's probably getting into the sub-Q space where it needs to be, but if they're jamming, it's probably going down too hard. But now, are we supposed to go out and tell our patients, when you show me your injection, show me what you're doing, and you notice that they're denting the skin in, you're probably going to say now, that's maybe a little bit too much force, but can you envision a scenario like this? Show me how you're injecting your insulin. I'm thinking you're using a little too much force there. And now the knowledge that you have, as Donna mentioned, 1 pound force is probably the optimal. Can you say to your patient, can you show me how you're injecting with 1 pound force? Can you get it as close to 1 pound force as you possibly can? That's probably not going to work, right? So we can say, gentle, but what is a better option is, can the medical device company develop a product that actually, somebody's excited out there, can they actually develop a product that takes that worry away from the patient so the patient doesn't have to think about it? They have to think so much about diabetes and insulin. They have to think so much about diabetes and insulin. We don't want them to have to now start worrying about their force and their force variability. So that's what we do. We try to make little innovations and little changes to already good products that are out there and take that worry away from the patient. So let me introduce nanosecond generation pen needles to you. So let me kind of walk you through the difference. What we see on the left here is what's currently on the market with BD Nano 4mm pen needles, and on the right is the BD Nano second gen pen needle. I'm going to look at 4 different elements in the issue here. So we're going to look at the box, we're going to look at the outer cover, we're going to look at the little inner shield cover, and we're going to look at the pen hub. So can you hear me all right? Can you turn the mic up a little bit so they can hear? Thank you. All right, so the difference here, you see this outer shield, the first difference is in the box. So with the BD Nano second gen, it looks very similar to the original BD Nano box. Right here, though, you see in that little orange box, it just says second gen where it said ultrafine. The second difference is in the outer cap. You see, Donna mentioned that there are some dexterity issues. People may have difficulty removing this outer cap. This is a bigger, fatter cap. It's got some big, heavy ridges on it so that it's much easier to attach that to the pen device, and it's also much easier to remove. Now, one of the big things that addresses that FDA safety communication is this inner cap. Some people actually think this might be a needle, and they leave it on and they forget, and Donna mentioned some of the issues that come along with that. This inner shield with the second gen is actually thicker, it's got layers on it, it's easier to grip and remove before an injection. And then finally, the hub itself is quite a bit different. You can see a very big difference between the new hub and the old hub. We call this a posted hub. This is a highly engineered needle base. What it is a contoured base, and it's got all kinds of concentric circles on there. And the reason it was designed this way was that it provides increased comfort and compensates for injection force variability, and it supports a more reliable subcutaneous injection. So let me just kind of blow this up and show you specifically what we're looking at here. This is the outer cover. It was designed to be easier to attach, addressing some of those dexterity issues. Hugely important, a much bigger inner green cap, easier to remove. Hopefully patients will not get this confused with a needle. They will realize that this really needs to be taken off. More comfortable injections with this wider base and a contoured area here, and more reliable 4mm injection depth. It was designed to minimize the risk of an IM injection, and I'm going to show you some studies to support that. So we did a study at BD, and it was just published this year. And what we found is when we did the study, we compared the BD second gen nano needle to 3 on the market conventional needles, posted hubs. And what we found, and I'm going to show you the data in the next slide, is that those conventional pen needles were shown to routinely inject deeper than 4 millimeters. They went even as deep as 6 millimeters at times, depending on the amount of pressure that was applied. And let me just kind of show you what happens with the posted hub versus a nanosecond gen hub. So this is the conventional pen needle. This is the skin, this is the sub-Q fat area, and this is the muscle. If you exert enough force on this pen, you can actually push that hub down and it depresses the skin, and the needle can actually go a little bit lower than you want it to go. That's probably at a depth greater than 4 millimeters. Where the nanosecond gen, it actually shows that it does not depress the skin as much and the needle is not going quite as deep. And if I can just give you an analogy to sort of explain what's happening here, it's sort of like a snowshoe effect. And so if you have a 150 pound person and they're walking along the snow, they actually can sink down. If you have 2 feet of powdery nice snow, they'll sink down in the snow. If you put snowshoes on that person, they still weigh 150 pounds. They're exerting the same amount of force on the snow. But when you put the snowshoes on, the force distribution goes horizontally rather than vertically. And so the snowshoes keep them afloat. So that's kind of the same thing that's going on here, although I think if I had an engineer explain it, it would be much more complicated than that. So I'm trying to keep it an analogy that makes sense to us, and that's one that makes sense to me. Does that make sense to you, the snowshoe effect? Okay, great. Okay, so here are the results of that study. This is a study that was done and very recently published. It was just published this year, so hot off the press. This was a study that was done in Yorkshire swine, and we used Yorkshire swine because Yorkshire swine actually have skin very similar to human skin. Hair follicles are very similar, skin thickness is very similar. The only slight difference in Yorkshire swine skin and human skin is they have those little twitch muscles that we don't have. You know, when you touch your cat or your dog, their skin twitches. Pigs do have that, but they have less of those twitch muscles in the abdomen, and so that's where we actually do the studies. There were 1,200 injections given, and they used different forces when they gave the injection, and they used 4 different types of needles. So they compared the nanosecond gen needle to 3 different posted hub needles. The forces were ranged from 0.25 pound force, there was one that was 0.75 pound force, 1.25 up to 2. Now you notice we're not going up to 4, where some of the things that Donna mentioned before. But you can see here down on the graph, we're looking at needle penetration depth. And what we're aiming for is to be right here along the 4 millimeter line. This is BD nanosecond gen pen needles, and you can see the mean there is just a little bit below 4 millimeters. Each one of these dots represents an injection. You can also see how tightly formed the injections are around that mean there, and it's very close to the 4 millimeter depth. You can see with needle A, the variability is quite a bit different there, and the mean depth is about 5 millimeters. With needle B, a lot more variability, and we're approaching 6 millimeters here. Now this is done with a machine. These are not humans, so it's very well controlled. So had they used higher force, they actually probably would have gone down a little bit deeper. And they actually did do a subset analysis in this study where it did show with needles A, B, and C that if you used higher force, that it actually did decrease the needle depth or it went down deeper. It did not do so much. It wasn't statistically significantly different with the BD second gen until you got to the 2 pound force. And I just want to put that graph back up that Donna had showed that had we used higher forces in that particular study, and there are some patients that use higher forces. I've actually used this force tool and had people do it, and there are people that will go up to 7 pound force, and so it can be very, very heavy-handed. So they can potentially increase the risk of an IM injection there. Okay. All right, so product availability, when is this going to be available? We have started initial U.S. distribution in select national and regional retailers. We are going to have a widespread wholesaler distribution. It is not everywhere yet, so don't go out tomorrow or when you get back home and start prescribing it. You may see it in your electronic medical record systems, but what we're recommending is please work with your diabetes sales consultant, or you can talk to people at the booth and figure out in your particular area if this is going to be available and when it's going to be available. So we're going to have a targeted rollout over the next few months. It's going to be available in some national retailers right off the bat, but it's going to be slow, or targeted, I should say, over time. So just, before you start prescribing it and get everybody frustrated, make sure you know if it's available in your area. So please talk with your educators, okay? Your diabetes sales consultant. So what other resources do we have? So that's it for BD nanosecond gen. We do have some other resources that are available to you and to your patients to try to improve their diabetes care. So we are working on a BD Diabetes Care app. You can go into the App Store on your phone and just download it. And there's some very cool videos in there about how to inject your insulin with either a pen or a syringe. So when you talk to your patients and you teach them how to inject insulin, if they get home and they forget, when am I supposed to swab with alcohol, or I can't remember what to do with these covers, it goes through step by step, and they're actually very good detailed descriptions of how to inject with insulin. There are places to log in glucose, there's nutritional tips. It's a product that's we're still working on it. So we would love feedback from you, positive or negative. So if you play with it, please let us know what your thoughts are about it, and we're continuing to try to improve that. And these are just some of the things that we're working on: data entry, blood glucose data, nutritional information. They can actually get articles that are in there as well. So, and then finally, I just want to mention that we do have a full line of products, including those that meet the recent clinical recommendations. As Donna mentioned, the 4 and the 5 millimeter pen needles meet the clinical recommendations to try to reduce the risk of IM injections, but there are some patients and there are some providers that actually, for whatever reason, there are different reasons that patients may want them. There are longer needles available if they choose to use them. So we do have 6, 8s, and 12s still available. We also have a full line of syringes, so there are some folks that are still on vial and syringe. Not everybody's on a pen. We have different barrel sizes. We have 30 units, 50 units, 100 units. The 30 units have half unit markings as well as full unit markings, and we have different needle lengths. We have 6 millimeter, 8, and 12.7 millimeter needle lengths. And I just want you to notice that with syringes, there are no 4 and 5 millimeters available at this particular time. So there is a difference between needle lengths with pen needles and syringes. Whoops, hit the wrong little button there, sorry about that. Okay, now some fun stuff. So every year, BD and Lilly get together and put on a customer appreciation event, and we appreciate so much everything that you do for patients with diabetes, and we really want to show our appreciation for all the hard work that you do. So this, if you've ever been before, how many people have been to this event before? Oh, a bunch of you, cool. So it's fun, right? Yeah, it's fun. So it's tomorrow night at the Marriott Marquis right across the way from 7 to 9:30. I do want to make sure that you wear your badge so that you can get in, okay? So wear your badge so you can get in. But please do join us. It's very fun. There's lots of food. You can network. It's really a fun time. And then I'm going to put in a plug for our booth. Our booth is exhibit booth 1211 right here in the exhibit hall. We have a lot of diabetes sales consultants who are there. They're very knowledgeable. They actually have samples of the BD nanosecond gen pen needles. They can show them to you and you can see how they work. They also have that very cool, as Donna mentioned, that injection force tool, so you can actually play with it and see if you can get close to that 1 pound force that's so elusive. And then, so you can play with that, and they can also mail you your findings. And then finally, Donna and I will be at the booth. I'm going to the booth right after this to man it. And Donna and I will also be there Saturday and Sunday from 12 to 1 if you have any questions. One of the other things that I wanted to mention about Donna is that Donna was the first healthcare provider in the country. We knew she was going to be giving this talk. She actually has had samples of nanosecond gen. And are you willing to talk for a couple of minutes about some of your experience? She can give you some actual patient experiences with the second generation nano needle. So I'll turn it back over to Donna. Thank you so much for your attention.
So I was able to use this second generation pen needle with a group of patients that I have 15 people who regularly come to an ongoing support group. So they all are insulin users, and they all went out with these pen needles, and they came back. It's I think there is one person in this group that has type 1, but all the rest of them have type 2. They've been on insulin for some time for the most part, and most of them are in their 60s or even 70s. So one of the things that we found that was very interesting is one of the women has developed some Parkinson's, and so she had the experience, and she's on a little bit of a blood thinner, so she was always bruising from her injections using the nano pen needle. And she came back going, "This is phenomenal. It doesn't wiggle anymore when I inject because her hand wiggles." So what Maureen was talking about that snowshoe effect, having that wider base really improved the quality of her injection, and so that she wasn't getting the bruising she was getting from using the traditional nano pen needle. As well, one of the patients that I mentioned who had her insulin dose increased 4 times because she had never taken off the little green inner shield, she is a part of this group. The group made great fun of her when this episode happened because they were like, how could you not know to take that off? She goes, "Nobody told me there were 2 needle covers." So she said it would be really hard to make that same mistake with this needle cover. I said, "That's exactly what I want to hear, Pat." So she reinforced, and the people with the manual dexterity issues, which we see a lot as we're getting older, had the issue that it was much easier to remove the needle cover and to attach the pen needle to the pen itself. So that was the feedback I got, and I hope you'll see the same kind of positive results with your patients once you're able to start seeing people using this product. So we want to thank you all for joining us for lunch, for your attention, and please feel free if you have questions to come to the BD booth. As Mo mentioned, she and I will both be there from 12 to 1 tomorrow and Sunday. Thank you very much.